So as Andrew said, my name's Laura Kane Andrews. I'm the safeguarding lead for Hampshire and Isle of Wight Fire and Rescue Service. What I'm going to try and talk you through over the next kind of hour, a little bit less, might hopefully get you some time back to get you a cup of tea, is just a little bit of an overview in regards to fire risks and vulnerabilities, which we're asking professionals from all types of agencies to consider in regards to the individuals that you are supporting. So this is not a fire awareness session in regards to the buildings that people live in or the offices that you work in or kind of hospitals and things like that. This is about people, fire risks that they face, vulnerabilities that they have in their day-to-day lives that may impact upon the fire risks that they can experience. And then what we're asking you to do as professionals that are engaging with those people, and then how we can help as a fire service. Effectively, we are at the point of we don't want anybody to have an accidental dwelling fire, and we definitely don't want anybody to be seriously injured or to die in a fire. But unfortunately, we know that that does continue to happen within our local authority areas. So we cover Hampshire, Southampton, Portsmouth, and the island, and we continue to review any fire incidents that results in a serious injury or a death, and we want to learn from them. So very similar to the Safeguarding Adults boards and the Safeguarding Adults reviews that they do, we review fire incidents, we try and pull out learning, we pull out best practice in order to try and prevent something similar happening in the future. And that effectively has led us to the training session like today and the other different training sessions that we do to our partners across the county, because we can't solve fire risk and fire death by ourselves. We are not the agencies and the professionals that are in there that are having conversations with people, hence why it needs to be that partnership approach. And the same as you, we have safety plans and kind of operational plans that we're kind of currently working to. We are currently working to our safety plan that ends in a couple of months, and then we'll have a new safety plan that kicks in from April. And currently there is a very strong focus in our safety plan about working in partnership with organisations such as yourselves. Because as I said, you know these people, you engage with them potentially on the phone, you might be going into their properties, you might be having risk assessments or care plans for them. And we need to ideally try and work to a point where fire is almost kind of business as usual and embedded into that organisational approach across the whole kind of system. So it isn't just a case of us finding out at the kind of the point when something gets incredibly high risk. What are we doing at those lower level kind of points to try and understand somebody's fire risk? Please don't think that I am asking you to log off from this session at 1 o'clock being experts in understanding fire risk and vulnerability. That's certainly not the case. And we are certainly not saying that as a fire service, we're not going to help you and we're not going to manage fire risk, but we need your help effectively to identify who it is that might be at an increased risk and how we can then work together to try and manage that risk and mitigate it. So some of the stuff I'm going to talk to you about today, you may have already heard about, which if you have is absolutely brilliant. This training session is actually quite timely because we've got a couple of updates coming out in the next few months in regards to quite a lot of what I'm going to talk to you about today. So if you haven't ever heard about it, it's good to put it on your radar now, but then also for you to keep an eye out on the updates that are coming out in the next couple of months with some kind of updated figures and some updated guidance. If you have heard about it, hopefully there's some kind of just some reiteration of kind of what it is that we can do, what you can do, and how that can kind of help moving forward. So just to kind of set the scene a little bit, you may have heard of something called the 4L SAB Fire Safety Development Group. So this is a subgroup of the 4 Safeguarding Adults boards across Hampshire, Southampton, Portsmouth and the Isle of Wight. That is a subgroup that is chaired by us within Hampshire and the Isle of Wight Fire and Rescue Service, and it focuses primarily on trying to manage and mitigate fire risks within our communities. So it's the FSDG, as it's commonly referred to, that takes control of completing those multi-agency reviews of any fire incident that's resulted in a serious injury or fatality. Now, at this point, it's really kind of important just to confirm that a death relating to a fire isn't a confirmed fire fatality until it's either gone to coroners or the post-mortem has been confirmed and the cause of death has been confirmed as being linked to the fire. It could be, for example, that somebody has a medical episode that results in them dropping a cigarette and that then causes a subsequent fire, but it's not necessarily the fire that has caused that person's death. So we review any fire where there is a death associated to it, but it isn't a necessarily confirmed fire fatality until that cause of death has been kind of looked into. But we'll look at all of them at that point to try and understand, is there any learning? Were there any agencies involved? What were the risk factors and the circumstances happening for that person in the lead up to the fire? Was there any opportunity for kind of fire risk to potentially have been acknowledged and potentially mitigated? Is there any best practice that was already happening for that individual that we can promote across the system to try and standardise that and kind of let that happen for other people? So very similar to safeguarding adults abuse. It's not about blame, it's purely about trying to identify what was happening and what can we do to try and reduce that happening for somebody else in the future. So we currently have a thematic review that we are working to and that we have data from, which included 39 fire incidents that either resulted in a death or a serious injury that occurred between the 1st of January 2019 and the 31st of December 2021. We did that 3-year period because before that, before the FSCG was ever established, we were asked by the Safeguarding Adults Board to do an independent thematic review of kind of what the current situation was, and that was in 2018. So we looked back 3 years. So we have a thematic review between the end of 2015 and 2018, and then we set up the FSCG, continued to review those cases. Then we have a second thematic review of the cases that the FSCG had reviewed, which are those between 2019 and 21. And then one of the updates that I wanted to share with you is that we are hoping in March that we will then be able to publish our latest thematic review, which will look at the cases that the FSCG has continued to review since the 1st of January 2022 through to the 31st of December 2024. So effectively, we are very nearly at the point of having 9 years worth of local data about people that are either being seriously injured or potentially dying from fires in our own county, in our own area. So we can always look at national data and we will always do that comparison. But understanding what is happening on the Isle of Wight, what's happening in Southampton and Portsmouth and Hampshire is incredibly useful for us to understand that local risk profile. But currently, that latest thematic review is not yet published, it's not quite been completed. So we are still using the 19 to 21 thematic review. And that, as I said, has helped us pull out those key risk factors, those key kind of circumstances and agencies to try and build that kind of profile as to what were we seeing most commonly. There'll be some risk factors that we'll see in one case that we won't see in another, and that will always happen in the terms that fire doesn't discriminate against people. But what we are certainly seeing is that there are risk factors that we are seeing more frequently than others, and they certainly seem to be linked to people who are in receipt of some form of care and support service from agencies such as yourself. So some of the statistics I just wanted to share with you from the previous review, as I said, hold fire for a couple of months and we'll have a couple more, a few more kind of updates in regards to these statistics that we can then compare to these ones. But the review that we're currently working from at the moment, out of those 39 cases, 79% of the individuals had needs of care and support. 56% of those were individuals that were in receipt of care and support at the time of the incident happening. Now that varied between carers going in 4 times a day for bedbound individuals, to individuals accessing mental health support, to individuals accessing support from their GP, voluntary service kind of sector support, all sorts of different kind of agencies being involved with people, but there was some form of touch point, some form of support being offered to them that they were kind of in receipt of at the time of that fire incident occurring. When we first look at them, the first kind of vulnerability factor for the individuals themselves, we had 88% of them who lived alone. That's a really important statistic, and I'd like you to kind of bear that one in mind in particular as we go through the rest of this session, because as the other risk factors then are also present, if an individual lives alone and there is nobody else there to acknowledge the fire, to respond to the fire, to evacuate or to call for assistance, everything is then obviously on that person. And if that person isn't able to do any of that for any reason or is impaired in doing that, there is no support network for them in terms of that risk and kind of managing that risk. So that's quite a vital risk factor. As is this next one, which is about smoke detection or a lack of smoke detection in the incidents that we reviewed. So out of the cases that we looked at, 18% of the incidents had no smoke detection in their property whatsoever. We know a smoke alarm isn't going to stop a fire from happening, but it is absolutely vital in terms of telling people that a fire has occurred or that something has gone wrong and therefore they need to react to it. 18% of those individuals didn't have that warning. They didn't have that ability to get told that something had happened, and therefore their chances of being able to react and respond have instantly dropped. We then had another 8% who had smoke detection installed in their property, but it wasn't working. And that was either because it had the batteries removed, or it kind of reached that point where actually it was past the recommended time for it to have been replaced. Smoke alarms, on average, normally about 10 years that they should be replaced. And we had smoke alarms in properties that have been up for 15, kind of 20 years and hadn't been changed. So a really big learning point that we're trying to share across the partnership is that if you can go into somebody's home and you can look and you can see if there's a smoke alarm on the ceiling, great, that's the first thing. But actually, we can't assume that it works. If we can, we should be testing those smoke alarms. We should then be having conversations about whether someone heard that smoke alarm. Do they know what that noise means? Is it in the right place? Have they got enough? And that's all the things that we can help with. But just you walking in, having a quick glance up and then actually testing it just means that we know, okay, they do have that warning if they ever did need it. We then had some other statistics in regards to the individuals themselves that I wanted to share with you. So 64% of the individuals that were involved in the fires had smoking as a risk factor. Now, we know that not everybody who smokes is going to have a fire. And the reality is a lot of it is about how that smoking behaviour is managed in a safe manner in regards to fire. So how are they holding their cigarettes? How are they lighting those cigarettes? A lot of the individuals that had a smoking risk factor that we reviewed, there were burn marks that were evident on either clothing or bedding or carpet, or there was a physical impairment that potentially meant that they were unable to safely hold their cigarettes, so potentially Parkinson's, that meant that they were dropping those cigarettes. And it's just about understanding, what does that risk factor mean for them? We're not saying everybody who smokes is therefore going to have a fire, but the reality is their chances of having a fire, if they're not managing that behaviour safely, does increase. We then had 38% of the individuals who had poor mobility or some form of physical impairment. So this again ranged from individuals who were bedbound and unable to self-evacuate and unable to remove themselves from a fire situation, to individuals who were able to mobilise independently, but they had to do that with the help of walking aids or kind of assistance or wheelchairs. And that would affect the time that it would take them to be able to respond. Or it would affect the time that it would take them to move away. So if they had dropped a cigarette, to move themselves away to a place of safety, not necessarily to evacuate, what does that actually mean for them in the reality of when a fire situation occurred? We then had 54% of the individuals who identified as having poor mental health as a vulnerability. And as I said, these are multi-agency reviews that we get this data from. So we have information from GPs, we have information from mental health teams, from adult services. And again, that varied in regards to individuals identifying themselves as having a mental health vulnerability, to systems and kind of GP systems or secondary mental health systems kind of confirming a diagnosis. So again, a whole suite of different kind of mental health needs. And again, it's about understanding, what does that mean for that person on a day-to-day basis in terms of their fire risk? How does that affect their decision making? How does that affect choices or decisions that they're making about smoking or kind of alcohol, potentially hoarding? What does that mean in terms of that impact, in terms of that risk for them? And then again, on a similar note, we then had a statistic of 46% of individuals having alcohol or substance use in the lead up to the fire. And again, doesn't mean that just because somebody is using substances or somebody is consuming alcohol that they're going to have a fire. But what does that mean for them in terms of their ability to react and respond? What does that actually mean for them in terms of their ability to cook safely or to manage their smoking behaviour safely? And what we were seeing is that the more of these risk factors that were present for an individual, a person's risk in terms of fire would just increase. So if you have an individual who, for example, is consuming substances or is consuming alcohol, their fire risk may increase. But if you put that in terms of somebody being intoxicated and smoking and being bedbound, the risk of a fire is instantly greater, and therefore the risk of them being able to respond and react from that will go up as well. So I guess in essence, what we're trying to move away from is a blanket approach of somebody being a fire risk or not. It's about actually trying to understand what's going on for them. What are we looking at in terms of those vulnerabilities and those risk factors, and how do we actually understand what that means? So you can look at this thematic review. The current one that is published is out there in the public domain. You can access it. It's on Safeguarding Adults Board's website. I can email it out so that it can go out to all of you who've attended this session today. And what that thematic review document will do will give you a breakdown of all the information and more of what we've kind of talked about so far. So this table that you can currently see is all of the risk factors that we identified from the thematic review of 19 to 21. So you can see that care and support needs was in the case of 79% of the individuals that we looked at. So that's the top one, all the way down to oxygen, which is at the very end. Now, oxygen is in there, even though there were no cases that had home oxygen or medical oxygen. But the reason that we included it is because it was present in the previous review that we did in the 15 to 18 data. So we wanted to show that comparison because, as you can see, the table in the top right gives the comparison between the two timeframes. But if, for example, you worked in alcohol and substance teams, you might want to look at what were the figures in regards to that. If you worked in mental health, you want to understand that. If you are a GP and you prescribe emollient creams, you might want to understand, well, what were we seeing from an emollient cream perspective? So all the vulnerability factors that we saw across the whole oral SAB picture are in that graph there. And then if you then wanted to understand specifically the island, or specifically Southampton data, again, obviously depending on where people work, the thematic review then includes this table. Appreciate it's probably quite small for you to see on the screen, but you can obviously look at it and kind of edit it and focus on what you need to if you look at the thematic review. But if you just wanted to understand the Isle of Wight cases, in this graph, you'd be looking at the grey boxes. So care and support needs, for example, out of the cases that we had for the whole 4L SAB area, one of those cases was on the Isle of Wight. Two of the cases that were individuals who were smoking were on the Isle of Wight. You didn't have any cases on the Isle of Wight, however, who were in receipt of care and support. That has changed in the last couple of years, and the thematic review that we're going to publish in a couple of months, you'll see that these numbers are different, and we have seen more individuals on the islands that are open to services. But again, let's focus on emollient creams, for example. You can see that is the 1, 2, 3, well, that's the fifth column from the far end. That's all pink. So the two cases that we had where emollient creams were present, those were individuals that lived in Southampton. Now, that is not saying that there are no individuals on the Isle of Wight who use emollient creams. What that is obviously saying is that out of the 39 cases that we looked at, those individuals who either sustained a serious injury or died in a fire that had emollient creams, they just happened to live in Southampton. But it gives you that understanding of, as I said, what is actually happening or what has happened in that time frame locally in your own area, and therefore what does that mean for you? What should you be considering or having an awareness of when you're having conversations about fire risk with those individuals that you're supporting? Now, obviously, we don't expect you to remember statistics or kind of understand specific kind of links. This is just giving you that kind of background as to why we're here. The next slide, if nothing else from the next kind of half an hour, you can remember this next slide is really what I'd like you to kind of focus on. And that effectively is about embedding 3 categories of fire vulnerability into your day-to-day work. So everything that I've talked about so far or shown you on those previous slides in regards to smoking, people being bedbound, poor mobility, poor mental health, alcohol, smoke detection, overloaded electrics, oxygen at home, we can categorize all of those risk factors into one of 3 areas. And this is something that we did locally as a fire service here, and actually has now been promoted through the National Fire Chiefs Council. So that's a national kind of network and governance in terms of all fire services. And they promote these 3 kind of areas as things that fire services should consider, but also partner agencies and other professionals should consider. So we're asking you to look at, when you're engaging with one of your clients or your patients or your residents, what's going on for that person as an individual. So if you were to take that person, move them 200 miles away, what's going to move with them? What's going on in terms of their physical health, their mental health? What's going on in terms of actually their ability to react and to respond? We could be talking about permanent risk factors, or we could be talking about temporary risk factors. If you break your leg today, you're suddenly going to find that your mobility is incredibly different for the next 6 weeks as it was before you broke your leg. What does that mean for people on a day-to-day basis? What's the actual impact and the reality of that? We're then asking people to consider what's going on in terms of behaviour. So this normally breaks down into 2 areas of either what is somebody doing or not doing that increases the risk of a fire starting. So smoking is a risk factor that will increase somebody's fire risk. But again, how are they managing that? If they are using glass or ceramic or official ashtrays, they are then emptying that ashtray into a bin outside. They're smoking outside, which would be even better. They're probably managing that risk as safely as they can. But if we've got individuals who are discarding their cigarettes into a plastic container or a milk bottle, for example, or straight into a waste paper bin that's got newspapers, crisp packets, toilet tissues, that's all combustible. And if you're putting a warm cigarette into that, the chances of that igniting is actually incredibly high. If we've got individuals who, as I said earlier, consuming alcohol under the influence of substances, are they able to manage that smoking risk? Are they able to cook safely, or have they potentially forgotten that they've cooked, that they're cooking, they've walked away from that, they've got distracted and they've not been able to go back to manage and control that risk factor? We then start to look at these risk factors together. So have we got an individual, as I said earlier, who's potentially smoking and they're bedbound? Have they got a physical impairment that means they're unable to hold on to their cigarettes safely? So we then start to build a picture as to actually how do these risk factors link in together and what does that then mean for them? And then the third risk factor is the environment that someone lives in. So this isn't looking at what is their home. That is important. We need to understand, does somebody live in a flat on the 10th floor of a high rise? Does somebody live in a semi-detached thatch cottage, for example? That will be important because whether they stay in the flat, if their neighbour has a fire, whether they evacuate, that will all depend on the type of property that they have. But for this, what we're really focusing on is actually what does their environment look like once they've gone in? Once they go through that front door, what does their environment look like for them? So in every single room, if they're hoarding, can they move between each room safely? Is there clear kind of exit routes and entryways? Can we get in? Can the ambulance service get in? If we needed to and there was an emergency, is there anything hindering us or slowing us down? Do they have smoke detection? Does it work? Linking back to the person as an individual, if we test that smoke alarm, can they hear it? Have they got a sensory impairment that means that actually they can hear it during the day, but they take their hearing aids out at night and then they can't hear it? Is there a cognitive impairment that potentially means they can hear the alarm, but they don't necessarily know what it means or how to then call for assistance or what they should do? So again, we need to start linking these together and actually understanding what does that mean for that person. Overloaded electrics, walkways, as I said, oxygen being in the property, what's actually going on around them that again either increases the risk of a fire starting or might impair their ability to react and respond. So as I said, if nothing else, that's kind of what we're trying to get people to start considering in your day-to-day practice, in the kind of the risk assessments that you're completing, the care plans that you're completing, the conversations that you're having with people, instead of just, is there a fire risk, yes or no? We need to drill that down a little bit and understand that a little bit more as to actually what might that mean for somebody. And what we typically have and conversations that we have with people, not just about fire, but about anything in life is, well, it hasn't happened to me yet, therefore it's not a problem. Unfortunately, fire doesn't really care about that, and that it will still be there. That risk will still happen. Whether it hasn't happened to you yet, that risk factor is still present, and therefore we need to try and have conversations to mitigate those risks. So something again that you may have already heard of is something called the Fire Safety Framework. So this was a guidance document that was published by the 4 Safeguarding Adults boards back in May 2021. What that means is that this is the second update that I wanted to inform you about, in the fact that this is currently being reviewed. We are hoping to publish the updated version of this framework in March. So it's currently being updated by partners. It will go to the Safeguarding Adults boards in March time for their final approval, and then it will be shared and cascaded across to all partner agencies in that time. So if you haven't heard of it before, please look at the current version that is published, but be aware that the Isle of Wight board and us as a fire service will be publishing an updated version in March and April time, and we're going to be doing some separate webinars about that and about what the changes kind of look at. But effectively, this is a frontline guidance document. It is not a 100-page document. It's probably about 20 pages at the moment, and a lot of that is templates. There's a lot of tables and kind of risk assessments that are in there. So it is an easy to use guidance document that anybody who's working with individuals can use. So whether that's housing, whether that's GPs, whether that's health, whether that's social services, and it effectively kind of puts into one place all the things that we spoke about so far. So it talks about the risk factors. It talks about those 3 categories that we've just gone through. It then encourages professionals to embed in their practice something called a person at risk fire risk assessment. Now, I fully understand that you complete risk assessments for all sorts of different things with your clients already. You complete care plans, and there is a potential that you're sat there thinking this is another form, another risk assessment. But I really hope you understand that the fact that we are seeing people locally being seriously injured, having life-changing injuries or dying in a fire emphasises the importance of why we need to have these conversations and do those risk assessments with people. So agencies can take the fire risk assessment as it is out of the framework. They can use it, embed that in their own organisation, or it is a guide for you to create your own or to amend your existing risk assessments and make sure that fire is embedded in there. It doesn't matter, however works best for your organisation, as long as fire is in your routine practice somewhere. It also then includes a safe smoking risk assessment. Now, currently, if you were looking at the current published framework, that has an emphasis on individuals that are in care or residential settings. One of the big changes that we've made to the framework that we're publishing in a couple of months is actually that risk assessment is applicable to anyone who smokes, whether they're in a care setting or whether they're in their own home. If somebody is smoking, we should then be looking at how safe are they from a fire risk to manage that behaviour. Do they need assistance? Do they need fire retardant bedding? Do they need a smoking apron? Do they need assistance lighting that cigarette, monitoring them, supervision? Is it that they need assistance with kind of extinguishing and discarding of those cigarettes? So we can't just kind of focus that on residential care. That's a big change that we've kind of put into the framework that will come out in the next couple of months. But again, it's in there. You can take it as it is, or you can kind of embed those questions into your day-to-day practice and your organisation, however works best for you. But effectively, what we're kind of at is the point of trying to get agencies to acknowledge fire risk and embed that in your practices, to complete some form of fire risk assessment or have some form of conversation, discussion about fire risk with your clients, and then to record that in your system and then consider whether you need to get us involved as a fire service. And that is where something called a safe and well visit comes into play. So again, I'm hoping you've already heard of this, but if you haven't, great, new information for you. So safe and well is effectively the intervention that we can offer as a fire service to somebody who's presenting an increased fire risk. Now, we are not keeping secrets in terms of what we do, what we look at. We don't have anything particularly different that we are then going to analyse. We just obviously look at it from a slightly different expertise angle in regards to fire. But when we engage with somebody, we are still looking at them as a person, we're still looking at their behaviour, and we're still looking at their home environment. As I said, fundamentally, that is how we understand fire risk. So that's what we've shared with you, for you to understand it to an extent, and then for us to provide support looking at those same three areas. So a safe and well visit is about trying to identify risks that somebody is being presented with, have conversations and provide advice about what can reduce those risks or what kind of mitigations can be put in place. We will test smoke detection. We'll ensure that they've got up-to-date and adequate smoke detection. We'll install new ones for free if that is something that somebody needs. It could be that they've got kind of the minimum level. So we recommend that somebody has one smoke detector per level as a minimum, and that will kind of be in central areas, hallways and landings. But if somebody is bedbound, we'd recommend that they have one within that room that they're sleeping in. If somebody is hoarding, we'd recommend that there are probably extra smoke detection in the rooms that have got a higher level of hoarding. Because the reality is, as I said earlier, that smoke alarm is about giving somebody the earliest warning as possible. So one smoke alarm in a hallway might not be sufficient if actually the room that they're sleeping in, where they're bedbound and they're smoking, that's the risk area. So we need to kind of respond to that, and we can do that. So we can provide that for free. We will also then have conversations about household escape plans. So conversations about how is somebody going to react and respond, what's their point of exit, how do they get themselves out, what do they do if they can't, so what's their plan B, what's the plan if somebody is bedbound or they're homebound. We have to acknowledge the fact that that's on the increase. People aren't going into care as soon as they're bedbound. Lots of people are staying at home, and absolutely right that they do that, but what does that mean in terms of fire risk? So if they have got carers or family coming in during the day, and it's those individuals who are doing all of the cooking, they're doing all of the washing, and that individual is unable to move around the property and do those things for themselves, the onus then should be on those other individuals, the family, the friends, the carers, to ensure that the cooker is turned off, the microwave is turned off, the washing machine is only used when somebody is present. Shutting those doors when that person then leaves. If that person who is living in that home is bedbound and physically unable to go into the kitchen, well then shut the kitchen door. Because if a fire starts in that kitchen, you've instantly given that person time for us to be able to arrive, to give them assistance and either deal with the fire or to evacuate them. If all those doors are open, that fire and that smoke is able to just move freely around that property, and we know that person can't move themselves away. So what can we do that actually doesn't affect that person's day-to-day quality of life, but does make them safer? I fully understand if somebody is bedbound, they don't want the bedroom door or the living room door shut all the time. I understand that. But there might be other doors that we can close that means that actually they are safer and doesn't have an impact on them. Having conversations with people as well about if they're bedbound or they're homebound, they physically might not be able to respond, but do they have a means of calling for assistance? From the reviews that we do, in all honesty, it worries me a lot about the amount of times that somebody doesn't have a means of calling for assistance to hand. They don't have a phone available within reach. They have a care line, but potentially that button, once they're in bed, the push button is then out of reach because they're not a falls risk. Thinking about actually what else can that do in terms of trying to notify somebody that there is a fire and that person having it on them is incredibly important. We can also make referrals for interlinked smoke detection through to telecare. So if somebody's got a care alarm and they've got smoke alarms, we can link the two together. They'd have to have new smoke alarms. You can't just link any smoke alarm that's already in place. But what that means is that the telecare gets alerted when the smoke alarm goes off. If it's a genuine mistake, it's burnt toast and the fire service isn't needed, fine. They'll have a conversation with the person and they'll kind of close the call down. But if it keeps going off and they're a little bit worried, they'll notify us, and we would much rather go and check that that person is safe and get turned around or kind of not be needed. Or if they don't get a response from the person, or obviously the person says, yes, there is a fire, they will call us and we will then send somebody out and we will go and investigate. There have been quite a lot of incidents where that has been the only way that we have been notified, particularly in the more isolated areas where neighbours potentially aren't right next to each other and kind of farming communities where kind of there's long distances. Can't rely on neighbours to hear people's smoke detection and then call the fire service. So it's again about considering, is that another safety net for somebody? It's not going to stop the fire, but it might mean that we get notified quicker, and it might mean that that person then gets saved quicker and we can help them. So all those kind of conversations that we can have. In addition to providing smoke detection, we can provide fire retardant bedding, throws or nightwear. Really important that people understand fire retardant does not mean indestructible. It will still burn, but it is designed to give people more time to respond to a dropped cigarette. It's not going to catch a light as quickly, but it means that actually people can try and kind of mitigate that risk. The reality is we know that people who are bedbound or who are physically unable to move themselves away from the situation continue to smoke. We know that people smoke in bed. We know that people smoke on their sofas, their living room kind of furniture. Us providing fire retardant blankets or bedding is a way of saying that risk is going to continue, therefore let's try and reduce it. It is not about saying, let us give you this, therefore that means you're now safe to smoke in bed. So people's understanding of what that means is really important. It also has to be washed in a certain way. So we give instructions about temperatures and kind of how that needs to be washed. But we would obviously rather try and mitigate that risk than not, but people need to understand what that provision of that kind of actually does mean. And then obviously what I fully understand is that fire risk is not your bread and butter day to day. And the same as I'm asking you to consider fire in your day-to-day work, we will consider other risks when we're going in to look at fire. So we will have conversations with people about their care and support needs, their health needs, their falls risk. Do we need to make referrals to sensory teams, care and support teams, to try and support that partnership perspective, the same as we're asking you to do? And then that little table at the bottom is effectively what I talked about when I moved on to this slide. So what in an ideal world we are hoping for is that partners have fire risk and vulnerability and the identification of that embedded in your own processes in some form. That in an ideal world will mean that there is a risk assessment that you complete or have fire specific questions embedded in your care plans and your risk assessment. And that then may result in you identifying that this person can have a safe and well visit from us. So just to confirm, from a safe and well perspective, we have an online safe and well form. So all referrals to us need to come through our website, and it will ask you specific questions about the fire risk. So it will ask you whether they live alone, have they got smoke detection, is there hoarding, is there a physical, cognitive or mental health impairment that affects them? And all of that effectively gets risk rated, goes to the relevant team, and then we will then contact that person to arrange that visit. Effectively, what I should say to you is that anybody that you work with, if they have a need of care and support, if they're opening or accessing your service and you've identified a fire risk or vulnerability, the chances are they are eligible for a safe and well. So again, embed that in conversations that you have with all of your clients and your service users. Would they like a visit from the fire service? If yes, make that referral through to us. It is really important that we understand the legality in regards of us completing safe and well visits. So you can refer anybody to us, but we may not necessarily be able to complete that visit if they haven't consented. There is no legal ground for us to enforce that somebody has a safe and well visit. We will not complete a safe and well visit because a housing officer is trying to gather evidence in terms of kind of issuing a notice of seeking possession. Safe and well visits are all about managing fire risk and making somebody safer. So we will work with partners, we will work with individuals, but somebody has to agree to us to physically go into their home and complete that visit. They also have to be present. If we look at those three risk factors in terms of the person, their behaviour and their environment, we can't do a safe and well visit to an empty house that somebody's going to be discharged from hospital back into next week. Because if that's the case, all we can do is look at the environment and we're not truly understanding the fire risk. So someone has to agree and someone has to physically be there for the safe and well visit to take place. If, however, you are managing a complex case, either under Section 42, under MARM, or independently, if it's not kind of reached those thresholds from a multi-agency perspective, somebody does not consent to us completing that visit, please still contact us, because it might be that we can then provide advice to you that you can then relay to that person. We might be able to then look at how can we kind of be maybe a little bit more creative about engaging with that person. Is there reassurance that we could provide to them, that if we were to actually speak to them firsthand and maybe answer some of their questions and alleviate some of their fears, that may help them? It could be that we are purely getting reassurance from us and advice from us so that you're not managing this fire risk by yourselves. Effectively, don't take an answer of no from that person, meaning that you can't speak to us. You absolutely can, and we would still like to help you, even if it means we can't physically go and see that person. But as I said, we do need them to agree for us to go in. We also need a way of being able to arrange that visit. So we have found that us turning up and doing door knocks unannounced, people don't tend to let in. They don't like us engaging with them in that manner. So we need a contact number or an email address to be able to engage with the person to arrange the visit or with yourself. You're also able to attend that safe and well visit. So if you are seeing that person regularly, you've got the rapport, you want to know what that safe and well visit consists of, we will absolutely do that joint visit with you. That's not a problem. And I would probably recommend that if that is about you managing that to put that person moving forward and that support for them, it's probably incredibly useful for you to be present at the same time. Because it could be you've done your risk assessment, we do the safe and well visit, and there is something that we identify that you hadn't, that you can then update your risk assessment with. If you're not present at that safe and well visit and not hearing that advice and those conversations, then you're not necessarily going to find out about that. What you will get at the end of a safe and well visit is confirmation from us if you provided your email address that a visit has been completed or that it was refused. What you won't get is a report of the conversations that we had or kind of the risks that were identified or whether we installed smoke detection. If, as I said earlier, there is a Section 42 or a MARM process ongoing, and you know that we've been involved or we've had a referral, I cannot stress enough how important it is that you involve us in that MARM or in that Section 42, because we can then share information about the safe and well under those two grounds. So we don't send safe and well kind of feedback routinely to agencies. We provide confirmation of kind of the outcomes. But from a risk mitigation perspective from MARM or Section 42, we will come to those meetings. We will provide an overview of what happened, the risks that were present, the actions that were taken, and that individual's kind of response to that effectively. So we can provide that, but obviously we are looking at kind of risk thresholds and kind of what that might mean. If you've ever got any questions about whether you can or can't request information or involve us, I cannot stress enough, either pick up the phone or email us. We want to be able to provide that assistance as much as we can. And if it is a case of we don't know anything about this person, we've never had a referral for them, but you're still having a MARM, let us know. We'll come along, and actually if there is a fire element, then we'll get involved. If there's not, we'll provide some advice and we'll step away. Just kind of contact us to provide that support to you and to that person. And then the very last thing that I wanted to say is that these training sessions that I provide through the board, so I do this for the Isle of Wight and the other three safeguarding boards that we cover. This is very much an introduction to safe and well, to fire risk, to the fire safety framework. We are able to come and provide specific kind of training to the team that you work in. So I've got 3 colleagues who are community development officers. There's a colleague of mine called Will Harrison who covers the Isle of Wight in particular. So Will is available to come and physically meet with your teams in your own kind of offices and your team meetings and your training days, or to do a virtual session like I've done today, specifically to your team, which goes into a little bit more detail about ignition sources, fire risk assessments. So this is kind of a bit of an introduction, but if you know that you're sat there now thinking, well, I've got a team of 20 colleagues who would really benefit from hearing this firsthand, please email preventiondevelopment@hampshire.gov.uk and we can come and do that. We've got Kelly and Alex as well who cover the rest of the county in terms of Southampton and Hampshire. Will also then covers Portsmouth. So between the 3 of them, we can deliver that training, as I said, face to face or online to your team. You just need to email that with a detail of kind of who your team is, what you're looking for, and they will get back to you to arrange that. But certainly consider whether that is something. If you're kind of sat there thinking, we really need to embed fire risk assessments in our organisations. We don't make safe and well referrals. I can't stress enough how much actually that training for your entire team might help you to kind of start putting that into practice. And as I said earlier, there is a new thematic review and there is a new fire safety framework that is going to be coming out in the next few months. So please keep an eye out. There'll be some comms coming out from Andrew at the Isle of Wight board and the other 3 boards about where you can find those new documents. And at any point, please do kind of contact us for any kind of guidance or questions. Right, I did see a question in the chat, so I'm just going to go to that and then I'll see if anybody's got any questions that they wanted to share. So Andy's put the thematic review link in the chat, which is great. So it can be found on the Isle of Wight Safeguarding Adults Board website in the resources section. And then there's a question about whether we accept referrals directly from family members and next of kin. Yes, absolutely. So professionals can make those referrals, but individuals can self-refer either on our website or by phoning our admin team. So individuals who potentially don't have access to the internet or would struggle to use a computer can call us and we'll take a self-referral that way. Family members, next of kin, neighbours, they can make referrals. But again, we have to have consent. What we have had in the past is we've had a neighbour make a referral to us because they are concerned about hoarding, for example, in their neighbour's property and the impact on them. If that's the case, then we can absolutely do a safe and well visit to that neighbour to make sure that they are safe. But what we can't do is go and knock on somebody's door and say, well, your neighbour's worried that you're a fire risk and therefore we'd like to offer you a visit. It very much, as I said earlier, comes down to consent and how do we manage that. If we know about that, we might make some inquiries with agencies such as yourselves to see if we can provide some assistance to you if you're engaging with that person. But effectively, we have to obviously look at what the circumstances. But yes, effectively is the answer. People can contact us, and then depending on what the circumstances are, we will then action that appropriately. That was a whistle-stop tour. That was a lot of information. I don't know if it's already been shared, but if it hasn't, Andrew, I'm happy for my direct email address to go out to everybody that's attended today. For any other questions, please do kind of send it to that prevention development one. But I don't know if anybody's got any questions they wanted to ask now.
Christine has the hand up for a question by the look of it.
Yeah, hello, hi Laura. I work in practice development. I've been supporting a newly qualified social worker recently, and we tried to do I think it's the person at risk fire risk assessment, Appendix 1. I think we can't extract that out of the policy. So what we'd like to do is do that assessment ourselves, to upload it onto our internal Paris database, and then we can share it with the fire service. That the gentleman we're working with doesn't want to, he's declined a safe and well visit, so we want to risk assess it ourselves and upload it to our systems and share it with relevant professionals. But is there another form of it that's on a Word document, because we can print it off and fill it in and then scan it, but that's a bit of a palaver for busy professionals. So is there anything there?
That's really so what I can do that. I mean, I've obviously got an editable version of the old framework, so I can put that into a separate document and I can email that to you. But that's a really good point in terms of the framework moving forward. So the new one that we publish in a couple of months, what we'll do is we'll make sure that there is a separate but the appendixes are effectively separate files that the boards can then host on their website separately. But I can do that. I can put the risk assessment into a separate document, and I can get that over to you in the next couple of days if that would be useful.
Yeah, I'd really appreciate that. Thank you.
Can you just pop your email in the chat just so that I've got
do.
it, and then I can send that? No worries.
Thank you. Thank you.
Question from Sarah Cook.
Oh, hi, Laura. It's not really a question. It's I'm the MARM coordinator, so it's great that you mentioned MARM. Just to really reiterate the importance of all agencies working together, and it's great that you've offered to attend MARM meetings if there are fire safety risks. So thank you for that. So it's just a comment, really.
Sarah, and I will be honest, we obviously initiate MARMs ourselves, but we do find it very kind of hit and miss as to whether we get invited. And as I said, even if we haven't engaged with that person yet, if you are aware of a fire risk, invite us along. We will provide that advice, we'll provide that guidance, and then we can potentially get involved moving forward. That's not a problem.
Absolutely, that's great. Thank you, Laura.
Anything else?
I think everyone's just so impressed they've been stunned into silence.
But,
yeah, absolutely. Thank you very much indeed, Laura, and thanks everyone for attending today. Appreciate it. So the recording will be available on our website in due course for anyone who wants to be aware or pass it on to their colleagues. But again, thanks very much indeed. Thank you.
Perfect. Thanks, everyone.
Thank you.
Thank
Have a
you.
good lunch break.
That's really helpful. Thank you.